thank you, Professor Fuji, Professor Bide, and Minister Mr. Abdullah for receiving us at airport, and I truly humbled by hospitality given to us at Mogadishu. So in this presentation, I will give you tips about how to read radiology for interpreting orthopedic pathology. So I have rearranged the presentations. First, I will go through bone pathology, followed by soft tissue, and then in the end, head and neck. There are 9 presentations, but I think I won't be able to go through all, so I will skip one presentation. So pathology residents are taught that radiological correlation is mandatory for interpretation of bone pathology. Henry Jeffy is a pioneer bone pathologist from USA who introduced this concept as a tri-dimensional view. Accurate diagnosis of bone lesions requires close communication between the pathologist, radiologist, and orthopedic surgeon. This approach results in the correct diagnosis in 95% of cases. Internet issue. So, may somebody tell me what is the practice in Somalia? So when you receive a bone tumor case, so how do you approach it? I mean, in terms of radiological correlation, do you rely on the report generated by the radiologist, or you go and discuss with the radiologist? What is the common practice? When we receive a bone pathology case, so we first interpret ourselves, then go to the radiologist to discuss that this is our differential, what is his or her differential, and then come with a consensus diagnosis. In our university, as yesterday Dr. Professor Shahid Parvez said, that we receive more than 100,000 cases biopsies in 2023. So more than 80% of the cases are from other hospitals from across the country. And it is mandatory for the referring orthopedic surgeon to submit radiology along the specimen. We process the specimen at our hospital, and then we go to our radiologist to discuss the differential. So the radiologists do us a favor. It is not their job because our volumes are very high. So exactly 15 years back, when I joined Khan University as an instructor in 2009, I received this case. This case, a referral case. So what are your findings? This is from the same patient. 2 different X-rays. Do you see a lesion? And if you see, what is the location? Epiphysis, a very small lesion. And what is this? So this is the post-treatment. The defect is filled with chips. So because this case was diagnosed as malignant at outside institute, so I went to the radiologist, and the time was very odd. I went to discuss the radiologist at around 3-4 p.m. and radiologist sitting at very far, and I displayed these images on the illuminator, and he said that this is osteosarcoma. So I said, this looks chondroblastoma to us. So he was very sarcastic, and he said that this is in the metaphysis, not in the epiphysis. Maybe after 200 years, chondroblastoma will be reported in the metaphysis. So he was very rude, and I cursed myself why I didn't study radiology myself before discussing this case to the radiologist. So after coming back from the radiology department, first I searched chondroblastoma of the metaphysis. So there were case reports, 5 case series, 2 case series, reported in the radiology journal. So I immediately emailed him the articles. Look, chondroblastoma can occur in the metaphysis as well. So nothing is 100% in medicine. The next day, I took this X-ray to our orthopedic surgeon and discussed with him. And he said, this is classic chondroblastoma. I said, what are the other image? He said, this is post-treatment. The defect was filled with chips. So I thought that because my interest is born in soft tissue pathology, so I should learn the radiological interpretation by myself and do not depend on the radiologist. And I searched the internet. There is a website, the radiologist assistant, which is very helpful. So I went through it, and I did a practice that whenever I receive a bone pathology case, before looking at the slides, I first see the radiology, make a differential diagnosis on the radiological films, and then see the slides. So in this way, I learned radiology over the years. So in radiology, in bone pathology, AP and lateral view are very important. So this is exemplified by this image. On anterior-posterior view, what is your interpretation? It looks like a danger sign. And it seems that the lioness is eating this cub. But on the lateral view, it is clearly visible that she is carrying the cub. So on one view, a lesion can look very dangerous. So both views are very necessary. So there is 7 parameters which are taken into account when reading bone pathology X-ray. The morphology of the lesion on plain X-ray, well-defined lytic, ill-defined lytic, or sclerotic. And next is important is age of the patient. So plain X-ray is very useful for interpretation of the lesion. It gives very useful information to determine benign versus malignant. And on MRI and CT scan, the benign things, lesions may look malignant and vice versa. So these are the 7 parameters which you have to apply when see a bone X-ray, bone pathology X-ray. The first is zone of transition. So zones of transition means relationship of the lesion with adjacent normal bone. So it is on the radiological images, it is called narrow or wide. So narrow means the lesion is circumscribed. It means a benign lesion. Wide means aggressive lesion, but it can be seen in the, there are few exceptions as well. The other is age of the patient. So age of the patient is very important because certain tumors occur in certain age groups. You have to see the periosteal reaction. I will explain this in next slides. Cortical destruction. Location is very important. because certain tumors have predilection for different parts of bone. So you have to see that if the tumor is located in the epiphysis, metaphysis, or diaphysis, and then the type of matrix, whether chondrite or osteoid, and certain tumors are like multiple. So multiple lesions have a different differential diagnosis. Here you can draw a line to delineate the lesion from the adjacent bone. So this is non-ossifying fibroma. This is in the diaphysis, but you can identify the boundary of the lesion. This is simple bone cyst, and this is aneurysmal bone cyst. So narrow zone of transition means a benign lesion. So in contrast, wide zone of transition means malignancy, but it can occur in the osteomyelitis and Langerhans cell histiocytosis as well. So in osteosarcoma, here you cannot say confidently where is the limit of the lesion. So like you can correlate the example in the tumors in soft tissue and other parts of the body that benign tumors are circumscribed and malignant tumors are infiltrated. So the same rule on radiology here, but there are few exceptions as well. Age of the patient. So there are many tumors which occur in patients less than 30 years of age. So if you see here, two are malignant, osteosarcoma and Ewing sarcoma, but vast majority are benign, like fibrous dysplasia, non-ossifying fibroma, simple bone cyst, aneurysmal bone cyst, osteochondroma, and chondroma. But after 30 years, there are few lesions, but most are malignant, like myeloma, lymphoma, metastasis, chondrosarcoma, and very few are benign, like enchondroma. So before learning the type of periosteal reaction, let's see revisit the histology of the periosteum. So this is, can you see the cursor? No. It is visible. So this is the normal resting inactive periosteum. It is very thin, and this is the cortical bone. Here you see these are the osteocytes. So this periosteum, it contains fibroblasts and osteoprogenitor cells. So when this periosteum is interrupted by spread of tumor or infection, the osteoprogenitor cells, which function as a stem cell, they convert into osteoblasts. The osteoblasts lay down new bone. So this is the activated periosteum. You can see the thickness. It is increased. So this periosteal new bone formation gives different radiological shapes, which helps us in determining the type of lesion. So this is exemplified in this diagram. So solid periosteal reaction means a benign lesion. Lamellated or onion skin means aggressive. Spiculated or sun ray appearance means aggressive. And Codman's triangle means very aggressive lesion. So we'll see this one by one with examples. So this is femur bone where you see a small tumor. This is osteoid osteoma, which is a painful tumor, and pain is relieved by taking NSAIDs, and the pain is at night. So this is the cross section of the tumor, very small tumor. So this is not the true periosteal reaction. This is the thickened cortical bone, which thickness or sclerosis occurs in response to the tumor. So it appears like there is periosteal reaction, but actually it is not. It is on this angle, it looks like thickened bone surrounding the tumor looks like thick periosteal reaction. So this occurs only in one tumor. It is osteoid osteoma. Lamellated or onion skin periosteal type of reaction, it occurs in two conditions. One is Ewing sarcoma. You can see the lamellations, vertical lines, and this is osteomyelitis. So radiographically, you cannot differentiate between osteomyelitis and Ewing sarcoma. So why this lamellation occurs? When the infection, inflammatory cells or tumor cells, they tend to spread and extend into the soft tissue. The periosteum lay down a layer of bone to stop the spread of infection or malignancy. Then on further spread, a new layer is being formed, and these successive layers of newly formed bone shown on this gross specimen gives this lamellated appearance on X-ray. Aggressive periosteal reaction is a sign of malignancy, like this is Sandre or speculated in osteosarcoma. This is Ewing sarcoma. You can see it extend into the soft tissue as well as a bulging mass. But it can also occur aggressive periosteal reaction in the osteomyelitis. So this is the Codman's triangle. It is seen in very aggressive lesion. On this specimen, you can see that the growth plate is not close, so patient is very young. And this is the metaphyseal tumor. So because it grows so rapidly, the periosteum, it doesn't give enough time for the periosteum to lay down new bone formation, and periosteum becomes lifted up. So this, you can see here, this lift up periosteum, like on the specimen, you can see, it forms a triangle, and this is called Codman's triangle. It means very aggressive lesion, and this is seen in osteosarcoma. Destruction of cortex is a sign of malignancy. And you can see here destruction of cortex in osteosarcoma and destruction of cortex in Ewing sarcoma. Location is very important. So in the long bones, in the epiphysis, 3 tumors occurs. So can somebody tell what are those tumors which occurs preferentially in the epiphysis? Osteochondroma occurs in the metaphysis. Giant cell tumor, excellent. The other is chondroblastoma. The third tumor is rare, but it also specifically occurs in the epiphysis. That is clear cell chondrosarcoma. Osteosarcoma occurs in which part of the bone? Metaphysis, mostly metaphysis, but 5-6% may occur in the diaphysis as well. And other tumors which occurs in the metaphysis are osteochondroma, benign tumor, chondromyxoid fibroma, and there is predilection for certain parts of the bone as well. If you see a tumor in the skull, so if a child, it would be Langerhans cell histiocytosis, common one. But skull is also common site for metastasis and myeloma. Spine is a common site for multiple myeloma. If we talk about malignant tumors, metastasis, then in benign tumors, osteoblastoma, ABC. Around the knee, most tumors are Ewing sarcoma and osteosarcoma. And in the tibia is common site for osteofibrous dysplasia, adamantinoma, and fibrous dysplasia. Chondroid matrix, actually calcification occurs in the cartilage, which gives this type of matrix. Here, this is, which tumor is this one? So the most enchondroma. So enchondroma is most common tumor in small bones of hand. So this chondroid matrix in phalanx, and here in a malignant lesion, chondrosarcoma. Osteoid matrix in case of osteosarcoma, osteoblastoma, and osteoid osteoma. Certain lesions are multiple. Here you can see multiple punch out lytic lesions in both metaphysis, diaphysis of bilateral humerus, clavicles, in this case of multiple myeloma. Here multiple lytic lesions seen in the femur, both femur, and this is brown tumor. Multiple lesions in fibrous dysplasia. Two different examples, but you can see multiple lesions proximally and distally as well. And here in this tibia, there are multiple lesions. So fibrous dysplasia. Multiple lesions in hand, what this could be? Osteochondroma occurs on the surface of bone. This is enchondroma. So multiple enchondromas occurs in certain syndromes. Excellent. Oilier's disease and Moffitt syndrome. So multiple enchondromas. And this is multiple osteochondromas. These are present on the surface of the bone. So multiple osteochondromas. Benign, yes, benign. Sometimes like benign lesions can attain very huge size, but when there are multiple osteochondromas, then there is risk of malignant transformation to chondrosarcoma, and it is increased to 5%. So in the solitary osteochondroma single, if the risk of malignant transformation is less than 1%. So polystotic or multiple lesions, the mnemonic to remember is FEMHE. Fibrous dysplasia, enchondroma, eosinophilic granuloma is the old name for Langerhans cell histiocytosis, metastasis, multiple myeloma, hyperparathyroidism, and infection. So 16-year-old patient, this is QS radiology. So where is AP and lateral view? Where the tumor is located, lesion? Epiphysis, excellent. So this is, they have circled it, epiphysis. Here, this is center. So if you apply those parameters, so the zone of transition is narrow or wide? Narrow. So one benign features. Is there any destruction of the cortex? No. So is there any periosteal reaction? No. So the patient is young, like below 20 years. You can see this growth plate has not yet closed. So it means it is below 18 years. So what could be the most likely differential? In chondroma, most common site is metacarpals. In long bones, when it occurs in the diaphysis. There are reports in the epiphysis as well, but if you, the common one is epiphyseal tumors are no, this is chondroblastoma. Chondroblastoma, benign tumor. So another quiz, two different patients. The first one is 7 year. So is there any periosteal reaction? Yes. So aggressive, and you see some matrix here similar to the bone. So if something looks like the bone, normal bone, but as a part of lesion, so consider this is the osteoid. So this is osteosarcoma, the first one. And the second 12-year female patient, which type of periosteal reaction is here? Lamellated. So lamellated differential diagnosis is Ewing sarcoma, excellent. And it occurs in the osteomyelitis as well. Okay, excellent. The first one, 18-year-old male patient. So differential is enchondroma. So you see all features of benign. See here, narrow zone of transition, no destruction of the cortex, no periosteal reaction. So benign enchondroma. Here, multiple lesions in female patient. So what could be the differential diagnosis? 55-year female patient. Multiple myeloma, other differential is metastasis. So in females, we see mostly carcinoma of breast presenting as multiple lesions. So this is multiple lytic lesions in case of metastatic carcinoma of breast. So any questions on this talk? So I have many presentations, so I want to finish. If none, then I will go to the next presentation. The title of my next talk is Challenges and Pitfalls in the Diagnosis of Bone Tumors. Bone tumors are one of the most difficult areas of diagnostic pathology with significant morphologic diversity and many overlapping features. This difficulty is further augmented due to recent increased use of true cut biopsies, small biopsy materials. So pathologies, bone pathology are already difficult, but on limited sample, it is more difficult to render a correct diagnosis. In 2020 WHO classification of bone and soft tissue tumors, they have refined the concept of some all entities and introduced some new entities. So WHO classification of bone tumors group as cartilage forming tumors, which is a major group. Then osteogenic tumors, bone forming, which are the bone forming tumors, notochordal tumors, osteoclast giant rich cell tumors, vascular tumors, and other mesenchymal tumors of bone. So I shall discuss the common challenges in diagnosis with examples. 45-year male, this case was submitted without any history, duration of symptoms, others, and on plain X-ray, what do you see? Where is the lesion? It is a septated lesion in the pubis and coming up to the iliac bone, and this is the CT scan. On CT scan, you see some matrix. So our radiologist said this is giant cell tumor, but histologically, this is the tumor. So any idea? Which broad classification? Is it cartilage forming tumor or bone forming tumor? Cartilage forming tumor. So cartilage looks blue under the microscope, and fortunately in this biopsy was adequately sampled, and you see some native bone trabeculae here. And the tumor is infiltrating in between these bony trabeculae, which is called encasement or infiltration. Here the higher magnification, a moderately cellular cartilaginous tumor. So here the diagnosis is easy. Radiology, it look easy, like aggressive lesion. Histologically, it is infiltrating the bone. So this is chondrosarcoma grade 1. But what about when the core biopsy or tissue biopsy sample only the lesional tissue and not the normal tissue? So in that case, it is difficult to differentiate enchondroma of chondrosarcoma. So enchondroma versus grade 1 chondrosarcoma, only the infiltration of the bone differentiates benign from the malignant. Otherwise, enchondromas can be also cellular in young patients. So in tubular bones, long tubular bones, this distinction is, it is okay if you mislabel the grade 1 chondrosarcoma, which is now renamed as atypical cartilaginous tumor. Because in the long tubular bones, the atypical cartilaginous tumor, it does not metastasize. There is very low risk of recurrence. So that's why this tumor is named as atypical cartilaginous tumor, similar to the concept in the soft tissue where you see atypical lipomatous tumor in the extremities and well-differentiated liposarcoma when it occurs in the retroperitoneum. So same concept is applied here. Because sarcoma means it should metastasize. So there is no metastasis when this tumor occurs in the long tubular bone, but when it occurs in the axial skeleton, means sternum, spine, there you, it is distinction is appointed, because here, there, in those locations, it behaves like a sarcoma, and in those locations, the resection is mainstay of the treatment. So here you see chondrosarcoma, but what about this one? Enchondroma, excellent. So enchondroma, here you see enchondroma, it is, the boundaries are demarcated, sharply demarcated from the adjacent bone, but in other parts, it is encasing the pre-existing bone. It is moderately cellular. So what happens if a biopsy takes only this part? So chondrosarcoma can have areas of enchondroma from which, like, it is transformed into the chondrosarcoma. So this challenge can be faced by any surgical pathologist, and it happened to us as well. This 24-year-old female patient. So radiological suspicion was either a benign tumor or Brody sepsis, osteomyelitis. It is a cystic lesion. So on the small biopsy, we reported this as enchondroma. When thorough curettage was done, there was bone infiltration. So the diagnosis was atypical cartilaginous tumor because this occurs in the long tubular bone. So fortunately, nothing went wrong to the patient because management was the same, but there was like mental torture to patient because first we said benign, then like a borderline lesion. So that's why radiological correlation is very mandatory. And what about these images? X-ray and the gross specimen. So what are the differential diagnosis on the X-ray? So it is like the osteochondroma, a surface lesion, mushroom-like. And what about the histology? What do you see there? So this blue is the cartilage and this pink is the normal bone. So what is your interpretation? Is this tumor is infiltrating the bone? So this is the pitfall. So this is actually residual foci of end-condyle ossification. So osteochondroma, remember, it looks like a growth plate. Cartilage, and below it the bone is formed from the cartilage. So in the large osteochondromas, you see in the deeper part residual foci of end-condyle ossification, which means this surrounding bone is formed from the cartilage. So in true invasion, it should percolate in between the bony tuberculi like you see here. So here it's like it takes the shape of the cartilage and the bones are the same shape. So this is the pitfall. And you also bias because sometimes large osteochondroma, oh, it should be malignant. So then you can make a misdiagnosis of chondrosarcoma developing in osteochondroma. So this is the images of the conventional osteochondroma. On the top cartilage plate and below bony, mature bony tuberculi. In between the bony tuberculi there is fatty marrow or hematopoietic elements. When it is large, there is necrosis of the chondrocytes as well, like you do not see the nuclei here. So this is all long-standing osteochondromas. There is frequent finding that the cartilage undergoes infarction or necrosis. So this is not a sign of malignancy. 23-year-old male patient, what about this? A zombie? Looks like it has an eye and mouth. So it is on X-ray, it is a surface lesion, but going into the bone as well. So on CT scan, you can see this multi-nodular tumor. Remember, the patient is young. So osteochondroma occurs in younger age group and chondrosarcoma occurs in older age group. So this patient is just 23, and this is chondrosarcoma developing in an osteochondroma. So the diagnostic histologic criteria is the cartilage lobules are cellular and arranged in lobules separated by fibrous septi. So if in this case we are fortunate that the sample also covered some underlying bone as well, which show here bone infiltration of an atypia of the chondrocytes. So this is chondrosarcoma developing in an osteochondroma. So radiographically, they said that if cartilage cap thickness is increased, then it means there is malignant transformation. But this is not the single criteria. Although if the cartilage cap is thickness, there is a chance that there would be malignant transformation. So histologically, cartilage cap should contain nodules of hyaline cartilage, cellular, which are separated by fibrous septi. They should show increased cellularity and atypia. So host bone permeation is the single most unequivocal criteria of malignant transformation in an osteochondroma. So here, two gross specimens from our collection. Here you also see the cartilage cap thickness is increased, but we did not see any histological features of malignant transformation in this case. But here you can see this is much wider, thicker than this one, and you clearly see the nodules delineated and going into the underlying bone. So here, histologically, there was malignant transformation in an osteochondroma. 25-year male patient, what about histology of this case? Benign or malignant? It is cellular, it is arranged in lobules. So, any idea? Benign or malignant? So, obviously, more cellular, you think more of a malignant lesion. But radiographically, it is present at the surface, and it is not aggressive. So, this is periosteal chondroma. Periosteal chondroma is rare. We have seen hardly 8 to 10 cases in our practice, but without radiological correlation, if you encounter an periosteal chondroma, you can easily misinterpret it as a malignant lesion, because this benign lesion, it shows increased cellularity and atypia and prominent nucleoli. A 33-year male patient, what is the location of the tumor? Epicenter is in the epiphysis, but it is extending into the metaphysis as well. So it is not very aggressive. So I received 2 cut biopsy of this patient, which were reported as 2 different diagnoses, which were malignant in other hospitals. So these are the 2 cut biopsies. So any idea what is the composition? Chondro. It is chondro, it is moderately cellular. Higher magnification, you may see here some binucleation. Here, like 2 nuclei in 1 lacunae. And on spatial stain, there was abundant glycogen, cytoplasmic glycogen, and S100 stain show positivity. So S100 immunohistochemical stain in like stains cartilage as well. It is a neural marker as well, but in it stains cartilage as well. SAT-B2 is a marker of osteoblastic differentiation. It was negative here. So what are your differential? Any guess? Chondrite. So benign or malignant? So it was difficult case, and in 1 hospital it is reported as chondroblastic osteosarcoma because of this pink cartilage. Occasionally cartilage looks like pink, which mimicked as bone formation, osteoid. So in 1 hospital, like it is called chondroblastic osteosarcoma, and others unusual chondrite and osteoid tumor. So this case was challenging to me as well. So I took the images and sent to a bone pathologist in Korea, South Korea. He said this is chondroblastic osteosarcoma. So I emailed him again. Look, the radiology is not of a malignant, like frank malignant aggressive lesion. And I told him because of the location, I emailed him that it looks clear cell chondrosarcoma to me. So clear cell chondrosarcoma occurs in the epiphysis as well. So this is long-standing tumor, so it extends into the metaphysis as well. So he said, if you don't see clear cells, giant cells, how you will call this clear cell chondrosarcoma? I said maybe sampling error. Then I sent this case to Professor Andrew Rosenberg. So you can see the email sent in 2019. So I told him that maybe sampling error, typical areas are not seen. So he said, I agree, looks like grade 2 on this biopsy. And you can also can rule out clear cell chondrosarcoma on resection. So he recommended this tumor should be resected. So on resected, this is the histology. The true cut biopsy went to this area, sparing the other classic areas which were shown here. So here you can see large cells with clear cytoplasm, central large nuclei containing prominent nuclei. So clear cell chondrosarcoma is rare, but you may encounter it in your practice. It looks like radiology is not very aggressive. And patient presented with history of pain, which sometimes maybe more than 5 years. So when we sign out few cases, the clinician email us to review again how this could be a malignant lesion because the lesion was like the long history of pain. So then we sent him the literature. This is the known fact in this tumor. So this clear cell chondrosarcoma show conventional chondrosarcoma in less than 20% of the areas. So you should also think when a tumor occurs in the epiphysis and a cartilage, so your differential should also include this tumor. 28-year patient you see a large mineralized tumor in the leg. Histologically, it looks blue, darkly blue, and then blue areas. Any idea what are these foci? So it looks like osteoid matrix, but what about this? What is the morphology of this? Round blue cell. So this round blue cell area, it looks like Ewing sarcoma. So this is case of mesenchymal chondrosarcoma. So mesenchymal chondrosarcoma have areas which morphologically and immunohistochemically similar to Ewing sarcoma. So additionally, you see some pink osteoid-like matrix here. So the pitfall here would be calling it as Ewing sarcoma or chondrosarcoma. So, but remember, Ewing sarcoma does not show such type of mineralization. So additionally, there is no cartilage is present in cases of Ewing sarcoma. So how to differentiate this from osteosarcoma? Osteosarcoma also, if you say small cell osteosarcoma, it does not show this type of cartilage lobules in it. So sometimes immunohistochemistry doesn't support to come a diagnosis, and you have to correlate with the radiological features in a mess because the behavior is dedifferentiated. Chondrosarcoma is very aggressive. So in that case, the radiologist, when I was in the Mayo Clinic, USA for 3 months attachment, so I saw a case of dedifferentiated chondrosarcoma on true-cut biopsy. And the biopsy was done by an interventional radiologist. The biopsy contained well-differentiated chondrosarcoma plus high-grade sarcoma area as well. So I asked the radiologist, so how you took samples from the different areas. So she said, obviously, to us radiologically, there was a low-grade area as well, or there was a high-grade area as well. So I took the sample from both areas. I said in our setting, like the radiologist hardly took a very few millimeter tissue and sent us and did an effort and correlate. So the onus, like from the radiologist, from the orthopedic surgeon, oncologist to the pathologist to do the job for all. 35 male patient in knee joint. So any idea? It is cellular, and the chondrocytes are arranged in clusters. So sometimes, and I go back to low power. Here, any idea? So this is, I will show the radiology. So without radiological, like here, multiple, this is specimen and this is the radiology. In the synovial and peri-articular area, this is the synovial chondromatosis. So remember, synovial chondromatosis also show increased cellularity by nucleation of the chondrocytes. So if you do not correlate with the radiology, then you may end up calling it as a malignant lesion. So here, few other examples where the synovial chondromatosis, surface synovium, and here you can see the increased cellularity of the chondrocytes. Pathological fracture. So pathological fracture or fracture callus sometimes gives you a very tough time, because there in the fracture callus, here you see immature woven bone formation. It is increased cellular, and here you can see mitosis as well. So in other areas, you see spindle cells, chondrocytes, and osteoid. So this combination, without correlating with the radiology, you may end up, depending on the age, call it osteosarcoma or chondrosarcoma or dedifferentiated chondrosarcoma. You can see the increased cellularity, but the clue is that these cells, they show small nucleoli, but there is no hyperchromasia. So what are the differentiating points? Between the fracture callus and osteosarcoma. So one is hyperchromasia. These two images are of osteosarcoma. You can see the nuclear enlargement and hyperchromasia plus host bone permeation. In contrast, this haphazard proliferation, but in fracture callus, there is gradual transition between fibroblastic, chondroblastic, and osteoblastic areas. The other histologic feature is the cells surrounding the bone, they are multi-layered. But in fracture callus, there are single layer of cells, like you can see here, single layer of osteoblasts lining the bony tubercle. The other is the, Dr. Shahid yesterday discussed about the usual ductal hyperplasia. The bone formation in fracture callus is woven, immature bone, but it shows like Roman arches, and in between this bony tubercle there is loose fibrovascular stroma. 18-year male patient, left humerus lytic lesion. So any idea without radiology on this case? Benign or malignant, or what is the lesion? It shows some cysts, giant cells, and some ovoid to spindle cells. So in this case, if you, on close inspection, you see few large atypical cells. These are very few, but if you see the radiology, so it is very aggressive. So sometimes the atypical cells this is telangiectatic osteosarcoma. The atypical cells are very few. So you have to closely inspect, not low power to call it as ABC. We have seen many cases in which the subtle atypia was ignored, and then those patients, they come up with recurrence and metastasis later. So telangiectatic osteosarcoma, the most pathologists concept is that for osteosarcoma, you have to find osteoid histologically, but it is not seen in like every biopsy sample. And one example is telangiectatic osteosarcoma. So in telangiectatic osteosarcoma, you may not see the osteoid matrix, like in this case I shown you. So it looks like ABC, but in the septa there are atypical cells, and plus there are giant cells. So sometimes you see only pleomorphic cells in a bloody background. Osteoid matrix is minimal, or in rare instances no osteoid is seen. But this telangiectatic osteosarcoma, when it metastasizes, it produces osteoid matrix. So this textbook images, it looks like a bag of blood. 25-year, next couple of cases, 25-year male patient. Actually, this case was misdiagnosed by us and other institution as well. But when it recurred, then we got the diagnosis. Here you see a lesion in the metaphysis and diaphysis. On casual inspection, you see this is narrow zone of transition and this is benign. So this is what happened with this case. But on close inspection, you see some, this is called moth-eaten appearance, like the insect eat the leaf. There is some irregular borders. Sorry, here. And here you can see it is extended a little bit further. So these are the textbook images, but example is the same. Here you see, what you see? Two components. One is fibrous, yes, you can see hyalinized areas, plus bone, woven bone. So these cells show very subtle hyperchromasia, not very atypical. So any idea? Benign or malignant, and if benign, what is the differential? If malignant, what is the differential? Chondromyxoid is arranged in lobules. So this is low-grade central osteosarcoma. So initially, we and other lab misdiagnosed this as a fibrous dysplasia. But on recurrence, we saw the subtle atypia and permeation. So this is the example of fibrous dysplasia. Sorry. So you see narrow zone of transition, but the earlier case there was subtle, like infiltration. It is cellular, but is not, the cells are not hyperchromatic. So this is low-grade central osteosarcoma. 22-year female patient. Where is the tumor? So posterior surface within the bone. But is this angle, it is behind the bone and it looks like some sort of periosteal reaction and aggressive lesion. So any differential? What are the differential diagnosis of surface bone tumors? Excellent, parosteal osteo and osteochondroma. So this histologically, it shows a surface cartilage, which is cellular, and below it, similar to the low-grade central osteosarcoma, you can see these highly atypical spindle cells present between the parallel seams of woven bone, immature bone. So now your diagnosis is still parosteal. So this is, so in approximately 50% of the parosteal osteosarcoma, there is a cartilage cap present at the surface or within the center of the tumor. So the differential would be osteochondroma. But in osteochondroma, between the bony tubercle, you see fatty marrow or hematopoietic element. But in parosteal osteosarcoma, you see mildly atypical spindle cells. 35-year male patient, ankle. So we see here mononuclear cells, giant cells, and in between, this is a matrix, looks like a matrix. Any differential? So this, without radiology, this is like, because in this benign tumor, like this matrix resembles, this is collagen actually. This is not the osteoid. Looks like osteoid, and I have seen here, you can see the sharp borders. So we were not provided the radiology, so we think that it should be, because this pink matrix, so this is the osteoid and should be in the bone. So we think in that manner. But actually this was close to the tendon. This is tenosynovial giant cell tumor or giant cell tumor of tendon sheath, which has collagen, which is closely mimicking osteoid matrix. So next couple of slides, quickly, 21-year male patient hai. You see a multiloculated lesion in the greater trochanter and neck of femur, and this is the histology. Any differential? ABC, excellent. But do you see that ABC, this, what is this matrix? This is the osteoid matrix or woven bone. It is frequently seen in the aneurysmal bones. So how you differentiate this from the neoplastic osteoid? Because the cells surrounding it are not atypical. These are benign. So in malignant, the accompanying cells which have produced this matrix should be atypical. So this is aneurysmal bone cyst. 19-year female patient, left proximal tibia. So any differential on? So it, on the MRI, it contains these white spots. This shows there is some fluid in the tumor, and it is seen in ABC. So what is your differential on radiology? Yes, why giant cell? Yes, you are right, giant cell, because it involved the bulk is in the epiphysis, but it crosses the metaphysis as well. So this is the histology. You see multiloculated cystic structures and here. So your diagnosis is GCT or ABC on histology? So, yes, sir. So on histology, it does not look like a giant cell tumor. Only this small portion of a relatively solid area is seen, which on H&E you cannot differentiate. So this is an immunohistochemical stain, H3G34W. It is positive in the mononuclear cells and negative in the giant cells. So this is giant cell tumor, which show extensive secondary ABC light change. So what would be the clue? Because the patient is also young, on the radiology, because the epicenter is present in the epiphysis. So you should consider extensive secondary ABC as well. And we learned it by our experience, by misdiagnosing a couple of cases. Then our differential is always extensive secondary ABC in our GCT as well. I skip this because we are 17-year male patient, pain and swelling leg. So you see tumor in the cortex. This is the true cut biopsy. Here you see a fibro-osseous lesion, a osseous component which is ringed by osteoblasts, and then a fibrous component which is blend. So any differential diagnosis? So what lesions come under the fibro-osseous category? Non-ossifying means there is no ossification, there is no bone. This is the fibro-osseous. So the lesions which come in the fibro-osseous category is osteofibrous dysplasia and osteofibrous dysplasia like adamantinoma. So cytokeratin highlighted few stromal cells. So this is the case I shown is osteofibrous dysplasia. But there is a variant of adamantinoma which is called osteofibrous dysplasia like adamantinoma, which radiographically and histologically very similar to osteofibrous dysplasia. In that case, you have to carefully inspect the fibrous component where you see subtle epithelial clusters. And these are highlighted on cytokeratin. So why this distinction is important? Because osteofibrous dysplasia like adamantinoma is aggressive. Osteofibrous dysplasia, even without treatment, it regresses after puberty. But the osteofibrous dysplasia like adamantinoma, it may progress to well-differentiated or classic adamantinoma, and it then can recur and metastasize. So the last slide, diagnostic challenges in classifying bone tumors can be managed by a multidisciplinary approach. Pitfalls may be avoided by a similar multidisciplinary approach. All stakeholders, which is radiologists and orthopedic surgeons, must know the potential pitfalls and understand the limitation of the each discipline, because our colleagues, they push us to diagnose something which we are not comfortable, and then when something went wrong, then the blame is to us. So to multidisciplinary approach, we can avoid pitfalls in classifying bone tumors. Thank you very much. Now I think a break.